would like to welcome everybody. Thank you for being patient, but Professor Rajesh Sinha, who is the chief instructor, he's already he has a talk in some other session. So what we are going to do is so this is a course which is dedicated to decision making in patients of keratoconus, and I think it's we are going to have highly specialized talks dealing with the situations where we can practically, bring it into our practice. And we'll start off by Colonel Professor Vijay Sharma, and who's the chief of ophthalmology at the AFMC, and his talk is: Should all cases of keratoconus be cross-linked? Colonel Vijay, please. Thank you.
Thank you, sir. So, can we have our slides, please? Yes. So, Professor Rajesh Sinha sir is also here. So, the most pertinent question is, should all keratoconic corneas be cross-linked? So, I'll be elaborating on that. So, first about collagen cross-linking. As we know, it was Wolensak et al. In 2003, working at the Technical University of Dresden in Germany, when they first time came out with they published a study of collagen cross-linking in 23 patients who had the keratoconus progression stabilized after doing the collagen cross-linking. So that was the first time, and that is how it came to be known as a Dresden protocol, because it was founded at University of Dresden. So what is the principle is the cornea is saturated with riboflavin dye, and after the saturation of the cornea, a UVA light is it is irradiated with ultraviolet A light at 370 nanometer, which lead to increase in cross links between the adjacent collagen fibers, and that lead to strengthening of the corneal tissue, and also it stops the further progression of the corneal ectasia. So that is the principle. Now if we see, there are multiple indications of collagen cross-linking which have been published in the literature. Primarily it is the keratoconus, for which only treatment which can stabilize the progression of keratoconus is collagen cross-linking. Other conditions such as pellucid marginal degeneration, post-LASIK ectasia, infectious keratitis, bullous keratopathy, chemical injuries, and TMD, in all these conditions, the collagen cross-linking has been tried and found to be efficacious. So it is being done. Now in keratoconus, now how do we go ahead and what do we do? In adults, it's very important to document the progression of keratoconus, and then you can plan for doing the collagen cross-linking. In children, you may not document, because in children, the keratoconus progress is quite fast. So in children, the documentation is not required. You can straight away go ahead with the collagen cross-linking. For isosmolar collagen cross-linking, the corneal thickness should be more than 400 micron. For hypoosmolar, between 330 to 400 micron, the hypoosmolar collagen cross-linking should be done. Now it has been done, the CXL has been combined with various other procedures in which the vision can be improved. It has been combined with them. For example, topo-guided removal of epithelium in keratoconus, or TREK, in which the PRK and CXL have been combined. In creatine protocol, PTK and CXL have been combined. So it stabilizes the keratoconus as well as it improves the visual acuity by combining these procedures. Similarly, in intracorneal ring segments also you can combine the collagen cross-linking. And there is photorefractive intrastromal cross-linking, that is a customized cross-linking. So there also the collagen cross-linking can be combined. Now, in addition to corneal thickness, age is very, very important factor to decide how to go about collagen cross-linking. As I told, in adults, you need to document the progression. In children, you need not document the progression. And if there is an earlier onset of keratoconus, there are higher risk of collagen cross-linking failure in children. And in very young children, you may have to consider a general anesthesia, because they may not be very cooperative during the procedure. And a more frequent follow-up is required in the children. Now, what are the criteria which decide that the keratoconus is progressive or not? Now, there are multiple criteria which have been given at the various times. For example, in the Dresden Protocol in 2003, it was what criteria they considered was increase in Kmax by more than 1 diopter, patient self-reported deterioration of visual acuity, and need for new contact lens fitting more frequently than in once in 2 years. So this is what criteria they follow. But presently it's a Gomes et al. Criteria. Now in Gomes et al. Criteria, they basically said that there should be consistent change in at least two of the parameters. Now which are those two parameters? That is progressive steepening of anterior corneal surface, progressive steepening of posterior corneal surface, and progressive thinning from the center to the periphery. Now, out of these three, at least two criteria should be met to call the keratoconus progressive. Why they did not give any values? Because values are specific for the type of instrument that you are using, whether you are using an OpScan or a pentacam or which type of Scheimpflug device. So based on that, the criteria will differ. So the values were not given. In addition to this, CXL can be done if there is a perceived risk of progression if it has not been documented. I'll come to some cases, case scenarios in the end. So protocols, now we have conventional protocols as well as accelerated protocol. So conventional epi-off collagen cross-linking is the Dresden protocol, and I'll just cover some of them because they'll be covered in detail in the subsequent talks. Epi-on is not considered to be very efficacious. It has poor efficacy, although it avoids the post-operative pain and other complications of epi-off CXL like infectious keratitis or persistent epithelial defect, but the efficacy is not as good as a epi-off collagen cross-linking as is done in the Dresden protocol. Now, of all the, whether it's a conventional or accelerated collagen cross-linking, now, the efficacy of Dresden protocol is still considered to be the gold standard. All other cases, be it accelerated or be it iontophoresis or they are not as good as the Dresden protocol, but they give the advantage of a faster procedure, patient comfort in the accelerated protocol compared to Dresden protocol, which is much longer, and maybe the patient may have discomfort for a long duration lying down for about 1 hour. So out of accelerated also, it has been found that if we use a 9 milliwatt per centimeter square for 10 minutes, that is the most commonly used accelerated protocol at present, and efficacy is almost as good as Dresden protocol. Now, as we know that once we do the accelerated collagen cross-linking, the oxygen consumption in the collagen fibrils happen very fast. So oxygen is required for increased number of cross-links. So various techniques, whether if you have to do oxygen supplementation, does it have a role? Oxygen is required because if oxygen is not available, the collagen cross-linking will not be as efficacious. So we need to supplement the oxygen in collagen cross-linking. This will be discussed in the subsequent talk in detail. Similarly, whether a continuous or a pulsed collagen cross-linking, what is the role at present? So again, the principle is same. For oxygen availability, the pulse one gives a better availability of oxygen and a better cross-linking over a period of time. Iontophoresis, we do not have much of experience. I think hardly, I have not seen many people doing it. Although low intensity electric field is created, current is passed, it enhances the riboflavin penetration, non-invasive epithelium not required to be removed, better saturation than epi-on approach, but again inferior to Dresden protocol. Now there are some conditions in which the collagen cross-linking should be avoided, which include a prior herpetic infection, any concurrent ocular infection, if there is a neurotrophic keratitis, if there is a poor epithelial wound healing, severe dry eyes, autoimmune disorders, and pregnancy. So these are contraindications to do the collagen cross-linking. There are some cases in which the collagen cross-linking failure rates are higher. So there are chances of repeat CXL in such cases, especially in children who have severe allergies and who have frequent eye rubbing if Kmax is more than 58 diopters and paracentral cones. So these cases have been found to have CXL failure. So you may have to go for a repeat CXL in these patients. Now, just a few examples. Now, this is one patient. In one eye, there was a corneal hydrops, and this was the OPSCAN finding in this patient. So, what should we do? So, there is a, if you see the steep case 48, thinness package 399. So, do we wait for documenting the progression? No. One eye already has an adverse event, other eye has significant keratoconus. So, straight away, one should go for collagen cross-linking in the other eye in which there is no hydrops at present. This is a pentacam of a patient with the 67 Kmax 67 and a thinness Pachy of 355. Again, we should not wait for documenting the progression in this patient because the corneal thickness is already, it's at the lowest level, lowest point when we can do a collagen cross-linking. So again, we should straight away go ahead and do the collagen cross-linking in this patient. So this is another patient. If you see the pentacam values, so thinness Pachy is 505, 15 and 506, and Kmax is 49, 49.9. So in this patient, you can wait for progression, documenting the progression. And if you find that there is a progression, 3 monthly or 6 monthly pentacam can be done. If there is a progression, then you go ahead with the collagen cross-linking. This is another patient. Again, this is a serous sham plug image with thinness Pachy in the right eye 428 and 376 and Kmax of 71 and 76. Again, in this patient, in the left eye, you have to go for collagen cross-linking rather than waiting for any progression in this case. And subsequently, you can repeat the procedure in the right eye. So, thank you very much.
Thank you so much. Hello. Mike? Hello. Well, I think so many of these issues are we are confused about, and Colonel Vijay has really addressed them very well. Is there any question for him? Anybody? Yes. Yes, please.
So it's the same as in others. Say you are doing a cataract surgery, so you can stabilize the eye. That is not a problem in GA. So all patients that we do otherwise the GA cases for the patients, so there is no issue in stabilizing the eye as such because eye will not be mobile. Only thing is instead of doing an intubation, you may use the eye gel or the other techniques so that child is more comfortable and subsequent complications are less, GA related complications are less. So otherwise there is usually no issue that we get.
We just have to ask the anesthetist that it shouldn't be too deep. If it's too deep, the eye will roll down. If it's if the anesthesia is a little less shallow, then it will go up.
Yeah.
So it's better to ask the anesthetist to give relaxant in such cases so that the eye remains still in the center. And as far as focusing is concerned, just a sharp margin of the focus will tell you that it is appropriately focused.
Yes. Normally, I follow my patients every 3 months. No, after the CXL? Okay, then 3 monthly. Ideally, 3 to 6 monthly you can do. If the patient can report to you 3 monthly, it's better. Otherwise, 6 monthly at least you have to follow up. So, over a period of 6 months. Yes. Post CXL, usually at 1 month we are repeating. Usually 1 day and 1 week we are not repeating. That is how we are following up. We give a BCL. So after on 1 day we just see for any issues as such immediate after surgery. And on the 4th or 5th day we remove the BCL. We stain. If there is no epithelial defect, we start with the steroids. And then at 1 month we repeat the pentacam, any sham plug device. Yes. So if it is associated with say allergy conditions, frequent eye rubbing, so you should go ahead with the CXL in children because it's likely to, earlier onset they are likely to go into very, very severe keratoconus if you do not intervene at a right time. See, it's earliest that I have seen is around 4.5 years, 5 years, Down's patient. So that is what I have done earlier. So if anyone has any other.
Yeah, I've done beyond 6 years only, and If there is allergic conjunctivitis, we should try to resolve that first so that the effect of CXL is reduced if there is significant allergic conjunctivitis. The second thing is that the risk of haze is also high if there is a significant allergic conjunctivitis. So we should try to resolve that, and then we should go ahead, and we have done it beyond 6 years of age. And because we have reported a whole series of cases of keratoconus prepubertal as well, and that can be seen even without allergic conjunctivitis. So that has also been reported from our center. So that's why it's better to, because it will further progress at the time of puberty. So it's better to handle it then and there only, halt the progression so that it doesn't aggravate. Allergic cases, the response will not be that good, and there is risk of haze also. So it's better. No, we have to keep managing the allergic conjunctivitis. That is important, at least till the time of 14, 15 years, wherein the symptom of allergy is very high.
Yes. Yes. So, I think we are preferring comfort more than the standard efficacy. So we are going in all patients with the accelerated protocol only. That is 9 milliwatt per centimeter square for 10 minutes. But yes, if Dresden can be done, the GA duration will be much longer in that case. So you have to weigh both the things, whether how long the child can tolerate, how old is the child, and also the benefits of accelerated and conventional both. Yes. 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 No. Once you do the hyposmolar for say around 20-25 minutes, keep on instilling the drops, and then you measure the PACI. If PACI has come beyond 400, then you go ahead, you start the procedure.
You know, thin corneas is the
See, the
topic
thing
of the
is,
next talk.
the thing is that in cases of keratoconus, what happens that the corneal epithelial thickness also reduces.
Yes.
And it is not 55 or 60 microns or that you see in a normal cornea. So you can have a 30 microns, 35 microns, 40 microns epithelial thickness. So somebody having say 367 or something, if you debride the epithelium, it will come down to 327, 330. And anything beyond 330, if you do a hypoosmolar, it will swell up to 400. So that is the cutoff, wherein minus epi, if it's up to 320, 330, then you can go ahead and do an hypo. Yeah, if that is the case, yes, it's better to abandon rather than to cause damage to the endothelium. And I will be discussing about the thin corneas only. So let's discuss in that, yes.
See, if patient can afford it and if you have the machine, you can do the pentacam. There is no contraindication to do the pentacam as such. Otherwise, 3 to 6 monthly, yes. Again, that depends how much, what are the parameters, they are borderline, or there is a good amount of the K max and the other values are good. Then you can follow up 6 monthly, that you can decide patient to patient basis.
And maybe in addition to pentacam, one should be doing a serial biometry also, because as these are children, they are growing. So we have to know whether the myopia is increase in axial myopia. It's because of change of curvature of this thing. So it's very important to do. Otherwise,
Absolutely.
sometimes we get confused. We falsely attribute increase in myopia to progressive keratoconus, which may not be so.
Yes.
Yeah, I think that's very important. I think in the interest of time, we'll move ahead to the next talk by Professor Rajesh Sinha. He's from the RPC AIMS New Delhi, and he's the chief instructor of this course, in a very interesting talk on cross-linking in thin corneas and oxygen supplemented cross-linking.
Thanks, Dr. Amit. I'll be talking about thin corneas, which we were discussing just now. So the biggest problem is that if the corneal thickness is less than 400 microns, then if you do cross-linking, there's a risk of damage to the endothelium. And that is what has been, we have been, reading for the last few decades. So one thing that has come up is hypoosmolar riboflavin, which Dr. Vijay was mentioning, which can be used in cases of thin corneas. And thin corneas as thin as up to 320 microns has been found to swell up to 400 by use of hypoosmolar riboflavin, and then you can go ahead and do it. The effect is not as good as conventional cross-linking, but there is some effect definitely, and it's better to do get something rather than nothing. So that's why cross-linking hypoosmolar is done in conditions wherein the cornea is thin. Second thing is that people have used contact lens assisted CXL, but the effect is less. Why? Because we know that cross-linking works mainly in anterior two-thirds of cornea. Part of it is discarded by contact lens. Then you have the UV rays are impeded because there is a presence of post-lens tear film. And that is also the reason why the effect is less. Then people used lenticule, smile lenticule over the cornea so that there is no post-lens tear film. But again following the same principle that cross-linking works in anterior two-thirds of cornea and you are discarding part of it, that is smile lenticule. So the demarcation line will be shallow and the effect will not be that great. People have also used transepithelial CXL, but it has been shown to have 1/5 the effect of a conventional cross-linking. So that's why we just thought that if we increase the thickness of the cornea and then do cross-linking, it will not only increase the tectonic strength of the cornea, but also enable us to do cross-linking with safety. And that's why we started this study almost 7 years back when we created a negative meniscus lenticule, stromal lenticule, and we did accelerated cross-linking in order to have increased bulk, biomechanical strength. And with the negative meniscus lenticule, it has an arc shortening effect because there is a central thin part of the lenticule and a peripheral thick part, so it will have an arc shortening effect. It will cause central flattening. We gave the terminology FILAC, that is femtosecond laser assisted intrastomal lenticule implantation with accelerated cross-linking, and it has been accepted for publication. Now, one thing we have to remember, we have to use it in cone size less than 6 millimeters, because otherwise if it's more than that, then the peripheral thick part will come over the cone and that will distort, that will further elevate the elevation of the cornea. So this is how we create a donor lenticule from microkeratome is used to create a 200 micron lenticule from a donor cornea. It is dried up and then the central 4 millimeter is ablated with excimer laser. Very simple procedure to create a negative meniscus lenticule. And we have a peripheral thick part, 75 microns is ablated, so 200 microns in the periphery and 125 in the center, and then it is implanted inside. When we started first, we started using the VisuMax machine, wherein we could create a 7.8 millimeter pocket. We created the pocket and infused riboflavin. But there we could implant only a 7 millimeter lenticule, and part of it was coming over the cone. And that is why we used to get a very strange and unpredictable result. So this is the lenticule which is inserted inside, and then it is straightened, and then you can just tap it and it straightens up nicely, and put riboflavin and go ahead and do a cross-linking. Then we moved on to FS200, no financial interest, wherein we could create a 9 millimeter pocket. So we could create a 9 millimeter pocket and we could implant an 8.5 millimeter lenticule. So this was the advantage. So we could dissect, inject riboflavin into the pocket, and then inserted this lenticule, negative meniscus lenticule, into the pocket, and then cross-linking was done. We also have a subset of patients wherein we have put a suture. In one group, we have not put a suture. We just wanted to see whether suture will have a more pressurizing effect so that we can have more arc shortening. I mean, that's only the results will say. We have not analyzed so far. And so post-operatively, we give antibiotic, steroid, and lubricant. What we notice initially that we create two interfaces. So there is risk of haze formation. So in order to reduce the haze, we started putting more steroid and prolonged steroid. And now, initially, when we used to give steroid only for 2 months or so, wherein we used to get haze, now we have moved on to 6 months to 1 year of topical steroid, and that is how we do, and we get minimal haze. Still, I would say that there is some degree of haze, and we have to be really careful in giving steroid. Particularly, initially, we have to give at least 6 times topical steroid so that the risk of haze is less. Because finally, cross-linking works by, covalent bond, and that bond creates a little bit of subclinical scar, and that, if you have 2 interfaces, the risk of that haze is more. So we have to give steroid to reduce that. And some of the cases will show as good as this, but not all cases will show as good as this. Some will have little bit of haze as well. So it does have some limitation. And we have moved on to, we are comparing it with Baumann stromal inlay as well, wherein we don't do cross-linking. And so just showing a few topographic maps. Now, this is a case wherein the K1, K2 was 53.9 and 59.2. Post-op, it improved to 52 and 53.7. So it improved significantly. This is one case wherein it was 52.7 and 56.6. Post-op, it improved to 49.2 and 50.2. And Kmax also reduced significantly. But having said that, if the cone is larger than 6 millimeter, the results can be bizarre, and you have to select the case. And that you can select the case by seeing the posterior float as we select in intracorneal ring segments. The results that we found out was reasonably good. We found out that, but having said that, it is not a refractive procedure. It is a tectonic procedure wherein the patient may not require keratoplasty perhaps for life, or maybe for very long period. That is the advantage. As I said, interface haze is an issue which we have to take care. And so in this study, we concluded that Filac provides tectonic strength, causes reduction in keratometry, has an arc shortening effect, but it's not a refractive procedure, and it should be avoided in very eccentric and large cones. Another thing that has come up, has been reported by Farhad Hafizi group, is adaptive fluence, wherein they have used 3 milliwatt per centimeter square in different thickness of cornea, and they have shown good results. This is sub 400 protocol. They have shown good results to as thin as 214 microns, which actually flouts the basic teaching that we have been doing, that if the corneal thickness is less than 400 microns, endothelium will get affected. So, as I said, sub 400 protocol flouts the concept of risk of endothelial damage in thin corneas, and we all know that 30 milliwatt per centimeter square for 3 minutes, that is accelerated cross-linking protocol, is not as effective as the 9 milliwatt per centimeter square for 10 minutes, as Dr. Vijay was mentioning, as the conventional Decision protocol. So how can 2 minutes, 3 milliwatt per centimeter square work in 214 microns cornea? So there is a big question mark in that, and that is why perhaps it has not come up. As far as CXL-based oxygen supplementation is concerned, the basis of this was that there was some animal study from Theo Seiler group wherein they showed that the oxygen concentration goes down to 0 in stroma once the eye is exposed to UV rays, and after 1 minute it goes to 0, and that's why they supplemented oxygen, and they found good results in animal studies. And this is from Avedro, no financial interest. This cost about 3,000 euros, and we created an indigenous oxygen goggle, which we reported, and it was published in European Journal of Ophthalmology. We connected it to anesthesia machine from where the oxygen was pushed into this periocular area, and the oxygen saturation was measured with this cannula. And this was connected to the anesthesia machine, and 5 liter per minute was the, 5 liter per minute was the rate, and we found out that the oxygen saturation was about 84 to 85 around in the periocular area. We did the study. There was a slightly better reduction of Kmax, but the results were not as dramatic as we had thought. More the oxygen, more the covalent bond, more the flattening. That's not the case. And we have just sent it, and it has been accepted for publication in JCRS, that there are certain other factors as well, and it is just not oxygen that is responsible for it. And we also compared an EP off versus EP on cross-linking with oxygen supplementation in borderline corneas, 400, 410 microns, and we found out that EP off was better than EP on with oxygen supplementation. So oxygen supplementation is not something which is a dramatic thing, which is the game changer. There's something else into it, and we are working on this, and maybe we can come up with some more ideas. So in conclusion, I would like to say that cross-linking is an effective procedure, an established procedure. In thin corneas, it has been used, many techniques have been used, but if we strengthen the cornea by intrastomal lenticule, that too with a negative meniscus, large diameter lenticule, we can have an arc shortening effect, and we will be able to use cross-linking as an effective modality to stabilize the cone and stabilize keratoconus and prevent the requirement of keratoplasty in future. Thank you very much.
I think what an amazing talk, and it's this kind of an innovation, I think, which ultimately will lead you to the ultimate cure for keratoconus. Colonel Vijay, any comments from your side, please?
Thank you.
You are implanting 200 micron thickness of the lenticule. So how much increase in corneal thickness does it cause? It must be compacting after.
Yeah. We are actually, you can call the next one meanwhile. We are actually doing it in eyes wherein we have a minimal thickness of 320 microns. So we put it at the level of 150. So we should have about 150 below that as well, so as to sustain it. So it increases the thickness to close to about 470, 480, and then it thins out after that. And it comes down to, like, when it goes to 480, 490, sometimes even 500 plus, and it thins out to about 440, 450, 460, but it's cross-linked as well. So stabilized and 450, 440 microns. As I said, it's a tectonic procedure. It's not a refractive procedure. For visual rehabilitation, we do prescribe miniscleral contact lens in these patients, and in most of these cases, the visual acuity is very good. Even with a mild haze, the miniscleral contact lens works well and has given visual acuity of 6.9. And a patient who has such a bad visual acuity, 320, 330 microns, irregular cornea, is having 6.9 vision and for life, then nothing like it, because as such keratoplasty also has its own problems.
Dr. Rajesh, do you think that cross-linking it accentuates the haze, like, because
Yes,
so
that is what I'm thinking, and that's
you
why.
try to just follow up,
Yeah.
and only in case of progression you go ahead with the cross-linking.
I completely agree with you, because cross-linking does cause haze, because I have used Baumann stromal inlay without cross-linking and it does not cause haze. The only thing is that, I'm doing a comparative study also. That's an ICMR project. And but the only thing is that, cross-linking has its effect. Whether without cross-linking only Baumann stromal inlay will be as effective as, stromal inlay with cross-linking, that is what we are comparing. And if it is working, then yes, cross-linking increases the risk of haze, but we have to give topical steroid intensively.
So with this oxygen supplementation right now, you would not recommend?
Yes, I think I have done 2-3 studies on these. Due to paucity of time, I had to hurry up. But oxygen supplementation in itself is not a mathematical thing that more the oxygen, more the effect. This is what is the punchline that I would like to say here.
And Dresden we know works anyway, without the
Dresden
oxygen.
works, accelerated 9 milliwatt per centimeter square for 10 minutes, works nearly the same as Dresden.
Nearly the same. Well, thank you. We'll have more questions towards the end if time permits. And I would like to invite Professor Arun Jain for his his talk, which will be on the contact lenses, and which is the mainstay of visual rehabilitation and various designs for keratoconus. I think that's a mainstay of treatment that we have for these patients. Sir, your talk, please.
Okay, can we have the slides? First of all, I'll thank Dr. Rajesh Sinha for inviting me to this inspection course, and I have been given this topic. Is contact lens is the mainstay of visual rehabilitation in keratoconus patients? As we all know, as the keratoconus advances a little bit, most of the patients come with the spectacle and they say they are not happy with the quality of the vision. So this study was done a long time back in 1998, which showed that whatever may be the stage of keratoconus, they need some type of optical corrections, and almost 80% patients of keratoconus need some type of contact lens, otherwise they don't get full potential of vision they have got. So whatever stage, whatever post-op stage, whether post CXL or post keratoplasty, you need some sort of optical rehabilitation, and I'm here to just share is contact lenses use is the mainstay of visual rehabilitation in these patients. So there are different types of contact lenses available to us in terms of soft and rigid and specialized lenses, more so the hybrid contact lenses. Indications of all are different for each patient depending upon the tolerability and size of the cone, the stage of keratoconus, and all those things. So we will come to these lenses one by one, and also it depends upon the grade of keratoconus. Like in mild cases where the K readings are lesser than 45, we can get away with these soft toric lenses or specialty soft lenses or a piggyback or a hybrid contact lenses, as well as Rose K2 in early patient, because to improve the quality of vision, because Rose K has aspheric design, it improves the quality of vision. In moderate cases, the mainstay of treatment is Rose K2 lenses or hybrid, but in advanced cases where the K values are very high, we have to resort to large size Rose K2 or scleral type of contact lenses. So depending upon the size and the location of the cone, also once we, yeah. So if the cone is small, paracentral, a contact lens fitting is quite easy. But if it is larger than around 5 to 6 millimeter, it becomes quite challenging, because the chair time required for fitting these cases is quite high. Maybe 2 to 3 times you have to change the lenses. That's why we have to have the help of specialized optometrists who are trained in fitting these lenses. And if it is almost covering whole of the cornea, you have to have a scleral type of contact lenses in these cases. Okay, thank you. So, right. So, coming to soft toric lenses, these are the type of toric lenses available in the market. These are only indicated in early keratoconus cases because they drape onto the surface of the cornea, so they correct only low cylindrical error. And the indication, as already told, early keratoconus, where RGPs are not tolerated, and spherical scleral contact lens has face to mask the corneal astigmatism. So rigid gas permeable contact lenses are the mainstay of visual rehabilitation in these cases, because the material is sort of high decay value and they are not very expensive. They correct the astigmatism to a large extent and you get mostly 6x6 vision. But initial tolerability is low in these cases because there is a break-in period for about 3-4 weeks. After that, they are become more comfortable and you can correct high cylinder and irregular cornea with these lenses. And based on the size of the contact lens, we can divide them into, so if they are covering the corneoscleral limbus. They are called corneoscleral lenses. Semiscleral are up to the 16 millimeter diameter. Once we go beyond that up to 18 millimeter, they are classified as miniscleral, and beyond that is full scleral lenses. And they rest on, depending on the diameter, either on the limbus or perilimbal or the peripheral sclera. So, fitting keratoconus has become quite easy as of now. It was way back 20 years ago when we were struggling with the fitting these patients. And today, this is the most common contact lens used for visual rehabilitation of keratoconus patients. The difference from the standard lens has a fixed optical zone and it doesn't correspond to the shape of the cone. And there is unwanted pooling around the cone. And these rose scale lenses have smaller optical zone diameter. They conforms to the cone, and so you don't have a pooling of tears around the cone. And fitting is very important in these cases. There should be light feather touch at the apex of the cone in these cases. This video is not working. So if it is too flat, it will lead to scarring at the apex as well as vascularization of the cornea. So it should have a feather touch in the center. And this is a represented case with the high K reading. And we did, you have to take all those specification required for contact lens fitting. We are not going into the details of that for the paucity of time. So this is how it should look like. There's a mild feather touch in the center, and there is no pulling of the dye around the cone. And this is another case where the high 6 diopter cylinder and visual acuity is quite low in the right eye. So these are the like a base curve of the lens. Then you have to decide the total diameter as well as the final power as well as the edge lift. Edge lift is also important because that is required for the exchange of tear behind the lens. And this is the pentagam of the case with very high K reading of 54 and 55. And this was fitted from outside and the fit was flat. So you can see there is scarring in the center because it is touching on the cornea. So that is not a good fit. And you can see so much of pooling in the eye. There is no feather touch, so it has led to a scarring. So we change the lens so that you have a feather touch in the center with minimal pooling. Otherwise, they will have a continuous progression of scarring in the center. This is a paper we wrote way back in 2006 and it is quoted widely. We described a new method of fitting contact lenses based on topography. Even Rose K, who invented these lenses, he written to me directly and he appreciated the paper. And now coming to the scleral lenses, as we have told, they rest on the sclera. And pros of these lenses are they have a good comfort, they are stable on the surface of the eye, they are highly customizable. They can be fitted almost in any case of advanced keratoconus or post-keratoplasty cases. And the handling is little difficult as well as they are very expensive. So that is the drawback of these lenses. And they are ideal for intolerant rigid lenses where regardless of the stage of the disease or main delay, and they can also avoid doing early surgery. So this is one type. So they have three zones: the central clear zone, a limbal independent transfer zone, and a scleral landing zone. So there should be a minimum of 150 to 200 micron clearance in the center, and mid zone is again should have a clearance of 50 to 100 microns. So I won't go into details of the fitting, and this should be the fitting. We should follow a 50-50 rule. There should not be too much impinging onto the scleral surface. It should not be like this. There's an edge lift. Edge lift will have, patient will be discomfortable, and this is too tight. It is digging into the sclera. So again, the exchange of tears, all those things doesn't happen. So this is an ideal fit in this case. And so this is a representative case with so much of reflection but highly irregular cornea, though the cone is central. And you can see there is a clearance of around 250 micron in the center, and patient gets a vision of 6/9 in this case. And this is the slit lamp picture of the same. You can see the accumulation of dye behind the lens, and you can if you don't have access to OCT, you can just compare this thickness with the corneal thickness. You can come to know how much is the approximate clearance. So this is the eye fitted with a scleral lens, and this is a post-keratoplasty eye. This is another post-keratoplasty eye. This can be easily fitted in patients of keratoconus who are fitted with these scleral lenses. So different stages of keratoconus, you have different options of treatment, either C3R or intracorneal ring segment or flick or PRK or phakic ICL or toric ICL or a surgical treatment in the form of lamellar or penetrating keratoplasty. But whatever you do, patients still need some sort of optical rehabilitation in terms of spectacle. And if they have a irregular astigmatism, which is there in almost all cases, you need a spectacle or some specialized contact lens. So in the conclusion, I'll say for rehabilitation, optical rehabilitation of these keratoconus patients, you have to have knowledge of these different type of contact lenses. And if you are not doing yourself, you can refer to your optometrist or any colleague who is doing these lenses practice. And I acknowledge this optometrist who has done a lot of job in fitting these lenses. Thank you so much. If
Thank
have
you,
any
sir.
question? Yeah.
It was a wonderful presentation, and it's true that if in cases of keratoconus, the mainstay of visual rehabilitation is contact lens, and even after DALC, nearly 70% of patients they do require contact lens. So that's very true, and with the advent of miniscleral contact lens, things have improved quite a lot, even in severe cases. We move on to the next talk, and that is by Dr. Anant Parthasarthi, and he'll be discussing about customized PRK in keratoconus, when and when not. And that's a good question, when and when not, because whether we should do it or not, that is one. And which are the cases who will improve, and what is the cutoff of thickness, what is the cutoff of other parameters wherein we can do it. Dr. Anant Parthasarthi.
Thank you for allowing me to be a part of this IC, Rajesh. I think for scleral lenses, Dr. Jain, what I find is that it's becoming more and more of my practice. I don't know whether it's the graying of the hair which is making me less adventurous.
Have really worked well in large cones as well as even after DALCs, wherein the landing zone is at the limbus, and some of the designs they have landing zones even beyond limbus. And these patients, they are very comfortable with these lenses. And we have seen cases wherein in one eye we have fitted corneal lens, and in the other eye we have fitted miniscleral lens, and the patient keeps telling that the other eye, I don't feel anything is there, but in this eye I do feel little bit. So the corneal lenses, the patient is not as comfortable. And the current generation lenses have become very good. They provide very good visual rehabilitation and comfort as well. क्या हुआ? अरे पहले से check करना चाहिए. क्या करते हो यार, बैठे रहते हो. Time होता है. Yeah, please.
What is your opinion regarding bilateral CCR in adults and in children? Whether you do bilateral CCR at the same time?
See, bilateral C3R, I would avoid doing it. In large majority of cases, it is keratoconus is asymmetric. As a rule, it is asymmetric. In case there's some issue, can Amit, can you just connect yours? Meanwhile, he will check. So in a large majority of cases, because keratoconus is asymmetric, so you may have to, you may just like to do cross-linking in one eye. And there are some reports, I mean, we do get referrals from everywhere of post CXL keratitis. So, to some extent, I would say we are a little scared that way that there is a risk of post CXL keratitis as well. So, there's no harm in waiting for some time, do cross linking in one eye, see how it behaves, and manage it well, and then maybe later on we can do it in the other eye. Yeah. 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 So that's why bilateral, we don't do it because safety is again an important issue. I mean, management and arresting progression is one, but safety of the cornea is also an issue.
You know, where the cross-linking does for 1 hour, the eye is open, basically, with everything
Kya hua?
off. So your OT environment should be cultured regularly. You should make sure the ventilation is proper and so many.
Okay.
Boss, are we good to go? Yeah. Thank you so much. And I'll try and see if we can keep it to the time. So I've been asked to speak on TopoLink, PRK, and collagen cross-linking. And ectasia treatments are broad. You got topo-guided PRK, you got accelerated and conventional, you got specialty contact lenses. Faking IOLs also fit into some of these paradigms. And what are the bugbears for patients with keratoconus? It's poor, uncorrected, or best corrected vision. You tend to have halos and ghosting. You have a patient's fear of losing vision. I'll start with one patient, a 43-year-old male government employee, underwent cataract surgery a while back and was referred to us for some cornea problem because the cataract surgeon felt that the surgery is perfect, patient is not improving, and the best corrected was 618. And when we actually looked closer, we found that patient had actually undergone a LASIK. So about maybe 10 years back, for a -10 in both eyes. So it's, remember the Hamilton, people who don't know the history are doomed to repeat mistakes. And we put them on a scan. This was the right, and this was the left eye. You can clearly make out it's actually a post-LASIK ectasia, which was the primary reason for drop in vision, not the cataract. And the suggested treatment was basically to do collagen cross-linking intacs. We went ahead with collagen cross-linking because that was the conventional wisdom. And follow-up, patient was stable, then lost follow-up, and came back in 2013 with something like this, with a slightly irregular cornea, definitely, but almost about 8 diopters across the pupil, which is a challenge. Now you got to try and correct this. And we then decided to offer the TopoLink PRK. And plan was maybe right eye we do the glasses and the contact lens, and the left eye we do a customized cataract surgery. And patient presented, this is the right eye, and there is some planning involved wherein you try and not correct all the spherical part, or you correct about 50% of the cylinder. And if you're interested, I could discuss it one-on-one with you. But there are some steps on the platform. This was the wavelight, which allows you to modify the protocol on how much you want to ablate the sphere and the cylinder. Aim is to basically maintain the sphericity. And if you look at the ablation protocol, this is the patient's cornea, which is on the right lower side, and this is the ablation pattern. So it does try and focus the ablation on top of the cone, and it does an additional peripheral ablation to take care of the myopic treatment. That is, you're flattening the cornea, so you need to actually steepen the periphery. And this was the other eye. And broadly, you can convert a cornea which is like this into something which is more regular. So this patient can now be given a good glass with a good refraction. You can actually get them about 6'9", 6'12". So this is pre and this is post. For the other eye, something similar. This is a more eccentric cone. So you are limited by tissue, but you can make it reasonably regular and then think about doing something with respect to your cataract surgery. So this is the left eye, 36 months follow-up, still reasonably stable. And we put this patient on the eye trace, and you can find that there is an improvement in the suggested clarity of vision. Patient also feels that the glare and the halos has come down. So when you look at interventions for irregular corneas, or for that matter keratoconus, broadly how I feel to define it is in front of the cornea, on the cornea, in and beyond. So on the cornea, specialty contact lenses. In the cornea, you're looking at CXL, PRK. On the cornea, CXL, PRK. In the cornea, you got rings, you got Smile, CXL, and beyond you're looking at phakic IOLs and IOLs as well. Now, CXL and PRK is a combination treatment where the combined ablation probably needs about 50 micron. The aim is, of course, not to give complete optical correction, and that is the bottom line when you're looking at these patients. You're still going to give them a pair of glasses or a specialty contact lens post this. What is the principle behind this? Principle is you got to image the tomography, topography, and the wavefront aberrometry. The TRK ablates and flattens the imperfections of the keratoconic corneas and tends to treat the high order aberrations. It improves the central corneal asymmetry, especially prior to collagen cross-linking. So I prefer to do this ablation before I put them on CXL. And it's not a new concept. It's been described in 2006 for form-fruste keratoconus. So the concept is not actually very new. There are, of course, multiple protocols. This is the Athens where they do a bit of sphere and cylinder, limiting it to 50 to 70 microns, suitable for early keratoconus. And there have been some good, reasonable results, and you can make out most of them about -3 kind of spherical cylinders. So you're not looking at very advanced beyond 5, 6, very unlikely. The epithelial thickness is important because we do know that in keratoconic corneas, the epithelium over the apex is always going to be lesser. So when you're looking at ablation, you may probably look at 50 microns as a starting point, and there are multiple machines, and I'll touch upon it as well. But now with most OCTs, you can actually get epithelial thickness. It's a good measure to before you start and punch in how much PTK or trans PRK you're going to do. In the PTK, the intended ablation is about 50 microns. It's basically, if you can get a measurement, it is good, or a random 50 is reasonably good. And you do a bit of ablation on top of the cone. So the conventional modality is that why would you touch ectatic cornea with laser? Because that will increase the ectasia. But here it's probably a very non-intuitive way of working, wherein you flatten the cornea and then do collagen cross-linking. So you're not fixing the cornea in an eccentric place. So that is the concept. We do have patients whom we have done collagen cross-linking done earlier, came back to us still not happy with vision. Maybe 3-4 years later, we've actually done a topolink PRK. Of course, there are some modifications on the nomogram, which we could discuss if you're really interested. So this was the first published report on using trans-epithelial PTK followed in patients with keratoconus, and you can actually regularize. So if you see this topography in the published case report, you get a flattening of the steeper part. The upper part is still ablated, but not that much. Now with newer nomograms, it is actually possible to do that as well. So broadly, people have combined it with intracorneal rings. We do have follow-ups of about 10 years of intracorneal rings combined with PRK. But the challenge is that the clarity of vision will never match a contact lens. You're still going to end up with a contact lens later. But it does help to stabilize, and the uncorrected vision improves. So these are patients who had, as I said, about 2.5 diopters. In about a year, you're stabilizing them to about a diopter plus. So they are within the range where they can comfortably manage with a glass, or if you still want to give them contact lenses. And stability is good. Over 1 year, most of them do have stability or have an increase in the vision. Now, I call it the NN Bangalore protocol because I told Rohit, I said, everybody has it after their city. Why can't you put it after your city? So basically, the concept is to look for the location of the cone. Central and eccentric is different. So you have Q hyperprolate. So you do a topolink correction with and without the refractive part. And the eccentric part, you're also doing an aspheric ablation. And if you have reasonable central data, a central pachymetry, then you touch the refractive part. And what is the cutoff? Most patients, less than 450, you're probably not being able to offer this. Then you're looking at either a plain CXL, or you would need to offer a ring, which is a peripheral implantation, so you have more thickness there. 45 to 55, which is probably a grade 1 to 3 in most classifications. You can combine with Intacs if you have a good thickness centrally. So post Intacs, if the patient actually moves the cone and you have some irregular part in the central part, you would of course be more conservative. You're not going to touch 3-4 diopters, probably a couple of diopters is what the max you can do. Now present indications is combination. There is a concept called TREC, which was released on the Swin machine. I have access to it, I'm slightly lucky, wherein the trans TPK, that is the PTK is the same, and they ablate about 20 extra microns on top of the cone, which is slightly different from the Wavelight platform, where they also do a hyperopic ablation. So it is only about 20 microns, that's the limit. They tend to flatten it. We have about 1 year follow-ups. Between the two, if you ask me, I prefer the wave light because I find that it's a lot more controlled in terms of the outcomes. You do get better refractive correction. You can, of course, use it post keratoplasty and post intacs. There is eligibility criteria which I mentioned, but an important fact is there has to be no active allergic disease, no active ocular inflammation, and definitely no central scarring of the cornea, because these would compromise not only the healing but also your results. So where does it all fit in? Basically, if I look at early management of keratoconus, you decide early and advanced, it is probably at the early part where you have a bit of progression, you got reasonably regular astigmatism, and you are thinking you want to give contact lenses. You can do CXL, you can follow it up with the toric ICL if the spherical event is significant, or you do a TPRK with the collagen cross-linking, give them a pair of glasses or contact lenses. In the irregular part also, you can combine Intex and TPRK. Intacs would be my preference in terms of rings as the primary offer to regularize it, bring the cone to the center, and then if you want, either give contact lenses or do a ablation. In conclusion, the topography guided ablation improves both the uncorrected, best corrected, the quality of vision, and of course the contact lens fit. Meticulous and methodical planning is essential to ensure optimal results, and it can be used with post grafts as well as post intracorneal rings. Thank you so much for your presence.
Thank you, Dr. Anand, for a wonderful presentation. And I had a few queries, but as you moved on with your presentation, you answered all those queries. So we can have queries later on. Due to paucity of time, we just move on to the next speaker, who is presenting a very important topic, and that is IOL power calculation in eyes with keratoconus. Most of these cases will develop cataract someday and will require IOL power calculation. So let's have Professor Amit Gupta, professor at Advanced Eye Center, PGI, Chandigarh.
Well, very good morning, and I'll be talking about cataract surgery and IOL power calculation, in particular in patients of keratoconus. So we know that there are various issues when it comes to a keratoconic cornea. It's irregular, it's multifocal, it's steep. And what happens is that the traditional keratometric associations, like the assumption of anterior and posterior corneal curvature, it no longer holds true. The posterior corneal power assumes a much more important role, and the standard K, which usually measures the central and steeper part of the cornea, in case of keratoconus, this is also not true. And the traditional K, which assumes a consistent curvature along the meridians, again, that fact is distorted in patients of keratoconus. Along with that, we are looking at a different effective lens position because there's a deep AC, and also many of these patients are myopes with a longer axial length. So these are all things which can, fudge the calculation of intraocular lens power. So two main things I'll be talking about. One is how to reach the keratometry, what to use, and which K to use in these patients. So I'll just be showing some literature and, if possible, some amount of our experience. So one study by Kamiya et al., and they recommended the use of total corneal refractive power instead of keratometry. Now, I'll just show you how to reach the total corneal refractive power. So if this is a pentacam cataract map, and in that, if you see the central part here, it shows the total corneal refractive power, and on the bottom right square, it will sum up all the important findings. So in their presentation, in their publication, they said that use the apex TCRP, and this is shown in that graph, right? Another study, which was by Watson et al., they said that in mild to moderate keratoconus, you can possibly go ahead with the K readings that you obtained, for example, from an IL Master 700. And in patients of advanced being defined as more than 55 that K reading, we can use the standard 43.25. So they said that the hyperopic surprise was lesser if we ended up using the standard K reading. So summing up on the K in K, that is in mild to moderate keratoconus, use actual keratometry, and in severe keratoconus, you can consider the use of standard K values of 43.25, or we can use a TCRP at 3 millimeters on apex. Now, which IOL formula to use? Very detailed publication in the American Journal of Ophthalmology, and and very exhaustive, and they compared all the outcomes of the formulae, and they concluded that one, when we are dealing with a patient of keratoconus, go in for a specific keratoconus nomogram of whatever formula you want to use, and the Barrett's keratoconus and the cane gave the best outcomes, and they also advised that you can use the TK values with the IL Master 700 in these cases. So again, the cane formula has been repeatedly shown in multiple publications to be possibly the most accurate of these formulas, as is shown in this publication in ophthalmology, and we can see that the percentage of eyes which are less than 1 diopters was significantly better with cane, and followed closely by the Barrett's keratoconus. How to use the Barrett's 2K Kasian formula? We can go to the website. K1, K2 values have to be inputted when we choose keratoconus. So you can see that on a drop down, you have to choose keratoconus, and the keratoconus displays this. Therefore, already corrections are in place. So do not feed TK1 and TK2 here. And at this point, we can we have two options here: predicted PCA and measured PCA. And then we can just feed in the data, whether we want to do the measured, or want to actual measured values or the predicted values. So we have to click on that universal formula button, and then it goes ahead, and these are the IL powers are then presented. So for paucity of time, I'm not like going into this. So we can choose the measured, or we can choose predicted from here. And also, when we are using the K values for keratoconus calculations, so in the IL master, we have this like on the square PK1 and PK2. So PK1 goes to the flat and PK2 goes to the steep, and we can feed this. So this is the actual posterior corneal astigmatism that we are feeding in, as obtained by the
is available on AIOL2025-IC123-Decision.
So very shortly, how to use cane formula now.
Friendly interface. One needs to fill the details of the surgeon and the patient. After evaluating the eligibility of the patient for toric IOL, you select the appropriate IOL. Then one has to select the Keratoconus option. Select the type of IOL, and it fills the A constant automatically. Target refraction is chosen based on the severity of the disease. Proceed further with the rest of the biometry details. It can be put directly from IOL Master 700. Axial length, K1, K2, and anterior chamber depth. Lens thickness and CCT are optional.
So I thought, like, practically how to use it. I think that's very, very important. We should just,
Provided data calculates the patient's IOL power for the given target refraction.
It depends on the severity of keratoconus. It depends on the surgeon experience. I do like to give a little minus. And of course, in more severe case, I'll just come. So this is answers your question. So what has been advised by Kane is this kind of a correction, that in stage 3, this is Amsler grading. So he recommends a -2 to -3 target refraction, right? Just a short case to sum up: -7 with -6 diopters of cylinder. And you can see this is the 4-map refractive and other maps. So we again go to that, we calculate the TCRP. So again, the challenge here is, we use various formulae in this patient as to try, K1 is 50, K2 is 56, and we can see this is the powers from the K1 and K2 and not the TK1, TK2 that we used. So we went ahead and we, so you can see that once you use K values of the IOL master 700, it's 3.5. If you are using with the Pentacam EKR 65, so some people have used that. It's a different IOL power, and with the Pentacam EKR map at 3 millimeters different. So again, just to show that we can have a discrepancy of results, and I did do an intraoperative biometry here, and it showed that +2, -2.6. I did implant +2, but possibly because it was coinciding with what we had calculated. So ultimately, we had just a cylindrical error, and that was being shown on. If you see the reading on the intraoperative biometry plus 4.74, we did have the almost similar cylinder, and so this is another detailed kind of, I think, just for the paucity of time, you can just take a photograph of this. This is by Moshifer et al., and they've said, they've given bonds to axial length and white to white to also decide the aggressiveness of our correction. Few surgical tips: standard temporal corneal incisions closer to the limbus to avoid disrupting the thinner cornea, suture the clear corneal incisions, use modified tunnel scale techniques, and the capsular visualization during, you might have some errors of depth of perception in these patients. Thank you very much. And thank you, Dr. Rajesh, for having me a part of the course.
Thank you, Professor Amit Gupta, for handling a very difficult topic, because there can be various queries and there can be various surprises in spite of all these methods that we follow. We can have a few questions once we have the presentation from Dr. Rishi. So let's move on to Dr. Rishi Swaroop, who will be talking on personalized dry eye therapy, the science of polymer selection in treatment plans.
Thank you. At the outset, I'd like to thank Dr. Rajesh for allowing me to be part of this. And so I've just modified the topic a little bit. Tear substitutes, what, when, and where. I think not just the molecule, I think it's important for everyone to be just able to have some guidelines on how to select your lubricant. So tear supplementation is one of the main strategies of medical therapy of dry eye, as we all know, and many other ocular surface disorders. And commonly they are called tear substitutes or ocular lubricants. So what is the mode of action of ocular lubricants? They reduce the tear osmolarity, increase lubrication, replenish the constituents of the tears, and dilute the inflammatory cytokines which may be in the tears and be causing all the problems that the patient has. So an ideal tear substitute should have a pH which is neutral to slightly alkaline, preservative-free, have a higher ocular residence time without causing blurring of vision, containing all the important electrolytes, and isotonic osmolarity between 181 to 354, and low cost. As we know, traditionally we used to think that there were three distinct layers in the tear film. Now we know there's a lot of intermixing of the aqueous with the mucin layer, and the lipid layer is distinct on top. So the normal tears contain water, mucin, lipids, electrolytes, and proteins. And whenever there is a disruption of this tear film, that's when you end up getting staining of the surface, which we clinically see as fluorescein or rose Bengal staining. So, like we mentioned, what is the important considerations when selecting a lubricant for dry eye? Cost. It should be coming from a trusted manufacturer. The active ingredient is of course important, and the preservatives and additives are the ones that help us select one over the other. So what are the viscosity agents? Polymers or hydrogels act as viscosity agents and enhance the viscosity, lubrication, and retention time. The mucous adhesive properties of hydrogels prolong the contact time of the artificial tears on the eye. So these are the different types. You have cellulose derivatives like carboxymethyl cellulose, which is available in India as 0.5 and 1%. These are the most common lubricants, and they are also the cheapest ones. In India, they have come under price control. They have desirable mucoadhesive and viscoelastic properties and have a reasonably high retention time on the ocular surface. Before that, we had HPMC, which was quite popular, 0.3, 0.5%. It again has good retention property and disadvantages that can cause crusting on the eyelids. The newer kid on the block is a sodium hyaluronate. It's a glycosaminoglycan present in natural tears. It's actually an excipient which is being used as an active ingredient. It has excellent viscoelastic, lubricant, and water retention properties, and it has a very good ocular surface retention time. I think this is the one active ingredient which actually stays longer in the eye, and therefore it probably has a role in certain specific types of dry eyes where you need a prolonged retention time in the eye. Then you have synthetic polymeric lubricants like carbomers, or like polyacrylic acid, which have high viscosity and good retention time but can cause intense blurring. Polyvinyl alcohols. These are synthetic polymers with low viscosity and adequate water solubility, do not cause visual blurring. Besides prolonging the ocular retention time by enhancing viscosity, it also stabilizes the aqueous tear layer. Povidone has mucomimetic properties, good retention, added to the cellulose-based solutions to supplement both aqueous and mucin layers, and added to polyvinyl alcohol to increase the wettability of the lubricant. HP guar is something which is used in combination with polyethylene glycol and polypropylene glycol as a gelling agent. It kind of binds to the microvilli on the epithelium of the cornea and forms a glycocalyx, which helps to kind of stabilize the surface of the eye. And finally, we have lipid options for lipid replacement. So you can we have now a couple of options available in the Indian market. They contain either phospholipid emulsions or mineral oil, petrolatum, etc. You can also use castor oil, which is present in some non-lubricant agents like restasis. So I use castor oil restasis even in my evaporative dry eyes actually, and it does help. So that is about the active ingredient. Next very important thing that we have to look at is the preservative. Why do we give preservatives? Mainly to prevent contamination and to increase the shelf life of the lubricant. Traditionally, we have detergent preservatives, which are the worse, more damaging preservatives like benzalkonium chloride, cetrimide, and polyquat. BAK-based lubricants have almost gone away now, but they are still, some of them are still available. Earlier we just had these, and polyquat ones are still available in many of the companies, even some multinational companies, although it's a very small concentration. Oxidative agents have minimal toxicity. These include sodium perborate and SOC or stabilized oxychloroquine complex. These basically don't cause too much of damage, and therefore these are the mainstay of the preserved lubricants nowadays, and they can be dosed reasonably frequently, unlike the detergent preservatives. So benzalkonium chloride toxicity depends on concentration, frequency of administration, and severity of the ocular surface disease. So typically you will not use BAK-based lubricants if you're going to dose it more than 3 or 4 times a day, because they can cause a lot of damage to the ocular surface. They can damage even the goblet cells, even reducing the production of mucin. So oxidative preservatives, stabilized oxychloroquine complex, basically when it comes in contact with light, it breaks down into water, sodium, chloride, and oxygen. And chloride is the one which is antimicrobial and kind of provides that protection from contamination. Sodium perborate is the other one. Again, aqueous environment, it breaks down into water, sodium, hydrogen peroxide, and oxygen. And hydrogen peroxide, as we all know, has antimicrobial properties. So how do you decide which preservative to use? So like I said, what I use is, if the dosing is less than 3 or 4 times a day, you can use any lubricant, even BAK or polyquat-based lubricants are fine. But if you're going to use dosing more than 4 times a day, I would suggest go for a milder preservative. And if a patient has a severe form of a dry eye, then certainly a preservative-free lubricant is the way to go. The only problem in these, you have to keep the cost in mind, and preservative-free typically are more expensive. In addition to this, how am I doing on time? I don't see a timer. Yeah, yeah. So other than that, we have to look at additives like electrolytes, osmoprotectants. So many of these lubricants have these additives which add value. They give value addition to a lubricant, and based on, again, the kind of dry eye the patient has and the affordability, etc., one can take a decision which one to choose. So which lubricant to choose? Choice depends on type and severity of dry eye, frequency and duration of use, cost, availability, packaging, ease of handling, patient response, clinical preferences. So ease of handling, I'll tell you, for example, preservative-free. If you get UNIMS, patients with rheumatoid arthritis whose joints are completely deformed, they find it difficult to put UNIMS. Or some of these bottles, Novelia bottles, you have to really press to squeeze out the lubricant, which is preservative-free. So you may want to give them preservative-free, but they may not be able to instill if they have to put it on their own. So you have to keep that in mind. So I've covered most of these points. So that's what I said. If your hands are like this, it will be difficult for you to put these UNIMs, and you have to think about that. Gels, again, are an important agent which one can use, especially at night. During the day, of course, you can't use them so much because of the problem that they cause blurring. So these are the different options that are available in the Indian market. So you have CMC 0.5%. Most of them are SOC preserved. You have lower priced and higher priced ones, CMC 1%. CMC with osmoprotectants, so these have additional electrolytes and osmoprotectants which give some value addition. HPMC is the one of the older ones, but they are still around, and some of them really work very well. And this is, I think, by and large the most common segment, the PEG polypropylene glycol segment. Some of them have polyquad, most of them have disappearing oxidative preservatives. Sodium hyaluronate has become very, very popular lately, and many options are available, including preservative-free options are now available in the Indian market. Gels, HPMC or carbomer gels are there. Carbomer is better because it causes less blurring of vision. So how do you choose? If it's aqueous deficient dry, I would say preservative-free or oxidative preservative. Low cost, so need for frequent dosing and prolonged usage, so don't go for very expensive ones, and electrolytes and osmoprotectants are a welcome addition. Evaporative, use something which has oil based if that's possible, and again, if you can get mucin secretagogues to go with it, that's even better, and at night again you can use gels and ointments. So take home, no ideal lubricant actually. There's no one lubricant which completes, satisfies all your criteria. So you can do a case-to-case selection depending on all the considerations we talked about. Viscosity agent is important, but it's not the most important factor. Preservatives, additives, and cost, I think all of these come into the decision making. Thank you.
Thank you, Dr. Rishi, for a wonderful presentation and a wonderful last slide. Yes, there is no ideal lubricant. One thing what I have felt is that if somebody is there are individual susceptibilities. And some people are more comfortable with, say, HPMC. Some people are more comfortable with this carbomer containing polyethylene glycol.
Yes.
Some are more comfortable with sodium hyaluronate. So sometimes we
have to just circulate and
we
see.
just have to
Change
it's
the-
a
yeah.
trial method, and if it works
agree.
in individuals, then I mean
Yeah.
all are equally effective, or anyone can be ineffective. So that's what and basically it's
I
for
think that's a very
palliative.
important point.
Yeah.
You just have to try. Sometimes some patients, they like the HPMC, the BAK ke saath CMC very much, Moisol. And
Yeah, true.
yeah, huh? Yeah. So,
Absolutely.
you're absolutely right about
Yeah,
that.
yeah, true. Thank you. Yeah, please.
I feel, I'm just curious. What we started doing was we were trying to combine the CMC with hyaluronate, because I find that they probably deal with different parts of dry eye, was my thinking. The second part was, how many of you actually check vitamin D? Is it important? Because almost invariably, if you check it in 80%, there would be some deficiency, and even for us,
Yeah.
I think. So, and we don't have that significant dry eye. The second point was in terms of what is the split between evaporative and aqueous deficient. I find there's a fair amount of overlap, and adding, even something as simple as hydration, which is every 2 hours have a glass of water kind of advice, along with treating hot compresses as an addition to what we primarily think is aqueous deficient, right?
Absolutely,
I
we
think
cannot
evaporative dry eye
dissociate.
is a very, very
Yeah.
large component of our
Yeah.
clinic dry eye, and we have
Yeah.
to specifically look for
Yeah.
that.
Yeah.
T-butt, I think, is the easiest thing to do. And
True,
if your T-butt
true,
is low,
true.
just do something for that.
Yeah.
Warm compresses is a great idea, and thankfully we have now oil-based lubricants available which really work well.
And we cannot dissociate eye from the body. That's very
Yeah.
true. I mean, his topic was what is the ideal lubricant, so that's why he was discussing that. But yes, vitamin D and other factors like systemic hydration and all these things, they do have a role to play. That's very true. Just we have maybe just 1 or 2 minutes.
I have a comment to make on his topic. So for trek, I think it's important for the audience to also understand when to do trek versus a topo-guided. So if your thickness is in that zone where you cannot really do a topo-guided, but you still want to do some sort of a correction of the surface, I think that's the small
Regularity.
range where trek has a role.
Yeah.
For example, if it's less than 400 microns, less than 300 microns, you obviously can't do anything there, or say less than 350 microns also. So you'll just kind of ablate that little bit of cone, 15 microns there, and leave it. And then you can go ahead and do a cross-linking. Yeah.
points. I think what Rishi is saying is that you can go lower rather than be comfortable with the 450.
No, what I'm saying is you can do topo guided when your corneas are thicker, but if it is thinner, then you would choose a trek.
Okay. Now, probably what I feel is we need to mentally be ready for the cutoff for only collagen cross-linking versus laser. So I think different surgeons have it differently. If now the advantage of varying fluence is you can even cross-link 300, right? So I think less than 300, I think it's a reasonable option to consider doing a bit of ablation. My cutoff for doing any procedure, only cross-linking would be 350. But if you're basically anything beyond 350, you can modify it and go ahead with what you're doing. The second point was of the best corrected, which is a good suggestion. If you have a patient with 6/6 with that irregular astigmatism, non-progressive, I won't touch. And I find that the concept that once in 6 months you do the scan, I find it, because there's such a lot of variability, a 0.3, if you get the same patient, same observer in the morning and evening, 0.3 will be there, 0.5 would be there. So you can't use that as a point for progression. So I feel the 6 month is very arbitrary. I prefer keratoconus to be a drop in visual acuity as a better indicator for progression rather than just your scan, because scan variability is about 0.4, 0.5 in keratometry.
Some people also keep refractive astigmatism as a point which suggests that what exactly is the change, because obviously you are not expecting any change in the lenticular astigmatism. So whatever is happening is in the cornea, and sometimes with different machines you can have different values. So a common thing will be a refractive astigmatism. So some people keep refractive astigmatism as a key thing to decide regarding this.
Perfect. And I think there is always a difference between the topographic and the refractive astigmatism, especially for advanced cones. So anything beyond 3 to 4, don't expect it to match.
No, do we?
Just we. Yeah. Yeah, we are detecting more, and perhaps it is becoming more as well because of maybe our systemic conditions that might be affecting, which we are not aware. Because
I feel it's easy access to topography. When I was doing fellowship, there were maybe 5 topographers in whole of Hyderabad. Now each practice has definitely a biometer and topographer, so it's at least most will have access, at least 50%, or have a common center where you can send it. So we are
just
easy
one
access.
quick last question, and we have to wind up because we are now overshooting.
Maybe,
Rishi, you want to take that?
So which lubricant would you like to? Cyclosporin, yes.
I think recurrent VKC, SLKC. Yeah, SLKC, certainly cyclosporin has a role to play. And the moment I see a patient with a redundant conjunctiva and superior inflammation, I will put them on a topical cyclosporin and initially also steroids, lubricants. And if it is tending to recur on stoppage of the cyclosporin, then it's better to go for a surgical treatment. Otherwise, you'll have to put them long term on this, which really is not practical.
Okay, just one last question. Yeah, just.
Yes. See, if it is advanced keratoconus, it won't progress that fast. You won't come to know during the pregnancy. The progression is much faster. Agreed. But if individual is planning a pregnancy, you can plan CXL before. Usually avoid in the first trimester, second trimester, because there is some radiations which are going on. So we do not do during the pregnancy. We just keep on following the patients, and once the after the pregnancy, then you can plan that.
so I have just one last comment. to
Yeah.
make.
Do we have any next session coming up immediately? Otherwise, okay, then we can have that.
So
Yeah.
just a comment or maybe opinion of, so do there concerns we were discussing PRK or transepithelial PRK, topo guide or otherwise, the previous guidelines were minimum 450, okay, without epithelium 400, and you have a leverage of 50 micron to ablate. So, but some of us are saying we can go down up to 300. So, are there new guidelines? Because we should not get away with this idea that we can do a PRK with the cornea of 350 micron, which may be 50 micron doing away for the epithelium, which is, I have not read anywhere, but what is the consensus for
Rajesh, you want
people?
to take that before I?
Yeah, I will take on that. I will avoid doing that.
Yeah.
And
So,
in such cases, because if it's a 350 microns cornea, there will be gross irregularity, which may not be handled by just ablating a few 10-20 microns of ablation. So such gross irregularities might require something else. Maybe, as I suggested, that in such thin corneas, we can do either a Bowman stromal inlay, or we can do a stromal negative meniscus lenticule with cross-linking, and subsequently provide visual rehabilitation by meniscus contact lens, because in all these cases we cannot provide visual rehabilitation by such PRKs or anything. So I would be a little hesitant in doing
I
that.
think there is one rider, because I feel the keratometry is and the astigmatism an important part.
Yes.
So if a 350, very unlikely it would be which I had put a limit of 50. Very unlikely 55, which very unlikely it would be in that range. Most of these Ks would be higher. They'll be a 50, 60, 55, 60.
Yeah.
So it may be, I guess, case to case basis is what I would suggest.
yeah.
And if 350 as collagen cross-linking, definitely.
Yeah, that can be done.
But
I
in
agree.
case you want to ablate, I think it would be on a case-to-case basis. For me, the K value and the irregular astigmatism would be something that I would.
Yeah, basically I also do that. The basic idea is to, like you also said in your presentation, to regularize the astigmatism if you can, so that it becomes amenable to either regular spectacles, or I have done a few cases, wait for 1 year or 1.5 years. If it's stable, I go for ICL in these cases.
Thank you, sir. That's entirely brings a new chapter, that when to do ICL in Keratoconus. So
We add it in your
we
next
have to
IC.
stop now. And
Just maybe last one.
So very thin corneas. What is the role of BCL assisted cross-linking?
I had mentioned that BCL assisted cross-linking is not as effective, is not very effective. Why? Because of two reasons. One, cross-linking works in anterior 2/3 of cornea, right? And part of it, of thickness, is provided by BCL and the post-lens tear film. So, and you discard that. So the effect is not good. Number two, it is a proven fact that the post-contact lens tear film that is there between the cornea and the contact lens, it impedes the penetration of UV rays. So that is also one reason why now nobody is doing BCL-assisted contact CXL.
And the hyposmolar, how effective is it?
Hyposmolar is effective, but not as effective as conventional. But yes, if as I said, that something is better than nothing. So it does have some effect, definitely. And so that's why one can think of doing it.
Yeah, but most of the present ones come with HPMC, which gives you about 50-60 microns.
Yeah,
So it
yeah,
is-
yeah.
Problem with hypoosmolar is the effect is short-lived.
Yeah.
So it will again become pain.
Yeah.
And with the with the hyposmolar dye, it leads to formation of these kind of lakes in the stroma. The effect is not equal, and it's very difficult to handle that hyposmolar. It just runs off all the time.
Yeah.
So one of the protocols is that you load with a routine, say HPMC dye, and while doing the exposure, you put isotone, this hyposmolar.
But very thin corneas like 350, 375.
Yes.
It's
So
also
then
the
that time you put hyposmolar because
And you
putting
reduce
it
the
before
fluence.
is of no use.
You got to reduce the fluence as well.
I think we will have to stop here, and thanks. I would like to thank all the speakers and everyone who participated in the discussion. Thank you very much. Can we have a group photograph, please?